Okay, so today we are going to discuss the issue of endophthalmitis and with our dearest panelists and eminent professors. So these are the topics that we are going to go through rapidly, and I will need your help to go rapidly with concise and to the point answers so we can wrap up all the topics of endophthalmitis. So, Dr. Salam. Okay. Dr. Salam.
You can hear us?
Are you okay? Can you hear us?
I got it.
So, for Dr. Salam, can you just define what is endophthalmitis?
So, endophthalmitis is inflammation of all the layers. So inflammation of the uvea and the other layers of the eye with involvement of the cavities of the eye. And although the term may imply just inflammation, which could be infectious and non-infectious, it's usually reserved for infectious, mainly bacterial,
So
and
this
fungal.
will come later. So, Dr. Khalid, when you are confronted with such an image or such a presentation, how you classify or think about the issue of endophthalmitis?
Yes.
How do you classify it?
Well,
what are the types of endophthalmitis? Is it the cause?
Well, of course, this looks to me as a severe form of endophthalmitis. I see that the cornea is involved quite.
Yes, this is the clinical picture. But what I'm asking about, any case of endophthalmitis, what are the causes? How do you classify it? Is it from an outside of the body, inside? Yeah.
You mean exogenous, endogenous?
So this is the broad classification of endophthalmitis. It's an infectious versus non-infectious and endogenous versus exogenous. With the infectious, as Dr. Salam was just saying, is the most common with those exogenous causes with acute postoperative or chronic postoperative causes, traumatic bleb-associated endophthalmitis after intravitreal injection and corneal or hypopian corneal ulcer. So, Dr. Suka, what is the most common scenario after what is the procedure that you commonly see in a case of endophthalmitis?
For me, I think it's related to the number of procedures itself. Cataract surgery is common. That's why it's the most common endophthalmitis I see, probably because of the incidence of cataract.
Yes.
Second place would be injections and pleb associated. So this means the pleb associated is much higher because injections are a lot versus trabeculectomy surgery.
Sure. So the most common cause of endophthalmitis is acute postoperative endophthalmitis with the secondary IOL implantation is the highest rate of endophthalmitis. However, we see a lot of cataract cases due to it's the most common procedure that is taking place in the ophthalmology nowadays, representing like 40 to 80% of the cases of endophthalmitis that we see nowadays. So, Dr. Mohsen, when do you suspect a case of endophthalmitis?
So it depends upon many things. First, the history of surgery or history of ICU or debilitating disease if I am suspecting endogenous endophthalmitis. Second is the duration or the day of presentation. For example, if you are suspecting endophthalmitis 24 hours or 12 hours post-operative, this is very rare. But if you are talking about 72 hours or something, it's mostly endophthalmitis. And of course, is a clinical picture and the complaint of the patient and the vision and so on.
Is pain is a must for defining an endophthalmitis?
If you are talking about diabetic patient or something like this, it may be painless because the patient with peripheral neuritis may have endophthalmitis and less severe pain.
Yes. Interestingly, in the endophthalmitis vitrectomy study, 25% of the patient presented with a severe endophthalmitis without any pain. And is it also a must to have a hypopion in a case of endophthalmitis, Dr. Mohsen?
No.
So you can have a case of endophthalmitis without hypopion, just with severe vitritis.
Yes, right? and the hypopion will appear later.
Okay. So, Dr. Mohsen, again, if you are suspecting a case of endophthalmitis on the 3rd to 5th day post-operative,
yes,
and there is no frank signs, no hypopion, no pain, how would you proceed?
I will treat and observe. I will observe the patient twice a day or every 12 hours maximum to take a decision. If it is endophthalmitis, I will go for intervention.
So you will start by observation.
Yes, under intensive treatment.
And if there is a progression, you will treat, right?
Yes, I will treat as endophthalmitis.
Sure.
If there is improvement, so the condition
So
is not.
your first option, you will observe.
Yes, you said that the condition is not frank endophthalmitis.
It's
Yes,
just a suspicion.
I will observe.
Dr. Suka?
If we mean cells post-operative, first day, second
fifth
day,
day post-cataract.
and you have lots of cells, 4+ cells, no hypopion.
Yes.
At least I would start fortify the antibiotics. I'd consider injection at the point.
Dr. Khalid.
Visual acuity is important.
Now I have a low threshold for suspecting endophthalmitis. Any unusual, unexpected inflammatory reaction post-operatively is for me is an endophthalmitis until proved otherwise. It's not that I observe that it might be something. I know my post-operative picture for all patients. Any deviation from that cells, minimal hypopion, vitreous turbidity, for me is endophthalmitis. Not only this, I proceed immediately with intravitreal injection.
Salam.
I think for me this is easy. If the vitreous is involved, this is endophthalmitis, and I will inject this patient. And the aim is to inject within half an hour. Vitreous is not involved, then I will give the patient lots and lots of steroid drops, not antibiotics, steroid drops.
So the main recommendation when you suspect an endophthalmitis, treat as an endophthalmitis as soon as possible. This will save your patient. So Dr. Mohsen, if you are confronted with this patient, how will you proceed? What is your next step? This is a 5th day post-cataract surgery, counting finger 1 to 2 meters.
Yes.
So how will you proceed?
Of course, this is a very bad cornea. However, I have learned that when you clean the anterior chamber, the cornea is not bad as you think. So
this is how will you treat? I mean, is there something you are going to order before treating? There are any investigations, or you are going to proceed with whatever regimen?
No.
So
Either if you are talking about tap and inject, or you are talking about vitrectomy, you are going to take a sample. This is the investigations required.
This is the specimen.
Yes.
Would you order any ultrasound before?
Of course.
Yes.
Of course. Yes.
Okay. So one of the workup that is very important, at least medical legal, is to order an ultrasound to evaluate the involvement of the vitreous and the density of the vitritis. If you took the decision to inject a patient and you did an ultrasound and you found a choroidal detachment, would you still inject this patient, Dr. Mohsen?
No.
How will you proceed?
I'm not going to inject the patient either with choroidal detachment or without choroidal detachment. I am going to do vitrectomy for this case.
So your opinion in such a case with counting finger 1 to 2 meters?
No.
This case.
This case with choroidal detachment?
No. There is no choroidal detachment. And you said a patient with counting finger 1 to 2 meters, you are going to proceed with vitrectomy directly.
Yes.
So you are not going to inject anyway.
Yeah.
So Dr. Salam, what is your preferred first option for treating this patient?
Yeah, usually what comes to mind is what would you do if it's your mother? And then the other question, what would you do if it's your mother-in-law? Right? So if it's my mother or my mother-in-law, I would just inject them.
And if
these can inject topical steroids.
And if there is a choroidal detachment, will you proceed with?
Yeah, I'll try to inject in another quadrant, but even if I inject in the choroid, I wouldn't worry.
That's okay. So the presence of a choroidal detachment definitely would not postpone or regret to do an injection. Unless there was a retinal detachment, definitely you will need a vitreoretinal surgery. So the second workup, which is very important, is the vitreous specimen. Dr. Salam, how do you do your vitreous tap? Do you use a cutter or a syringe?
So we give subconj anesthetic, and we use a trocar. We put a trocar in the clinic, and then we use a syringe through the trocar.
So you use an insulin syringe through that trocar? Right?
No, we use a 25 needle through a 23 trocar. Then if it becomes, if it's dry, then we don't worry. We inject and do an AC tap.
Dr. Suka, how do you take your tap?
Practically, I don't like going to the vitreous, trying to pull on the vitreous. The cutter would be perfect. I do it when I'm in a vitrectomy, but generally I'll take AC tap action. I don't take the vitreous first.
And Dr. Khalid, do you take your step?
Not in the office. I'm not as prepared as Ahmed. I do this in the OR with before starting, of course, infusion into the vitreous, and this is at the beginning of vitrectomy. I take the vitreous sample, but not in the office.
Okay, Dr. Salam, now you have this situation, and it was prescribed even in the endophthalmitis vitrectomy study that we take this by manually aspirating the vitreous, and you have this dry tap. What is your next step?
That's a great question. So if you look at most of the cases that get injected or get vitrectomy, they get actually sterile by one injection. And we're using empirical treatment that covers nearly everything. So I wouldn't worry much about the results of the tap. So if it's, in short, if it's a dry tap, I just stop like this, inject, then do an AC tap to just lower the pressure.
You will omit the tap. So on this dry tap, these are the options. You can omit, you can go with a cutter, and you can change the site. And this again was prescribed before in the 1995 for the endophthalmitis vitrectomy study, because having a culture is much better, as we are going to see, regarding the issue of retreatment. Because if the culture is negative, this will make like a bias, and you are not going to have a true microbial entity that you are going to treat. So just by changing the site of taking the tab, you can have now a good specimen that you can send for a culture. Dr. Suka, how many of your culture and sensitivity you get this picture with negative AC or a negative vitreous sample?
50 to 70% of them.
And how do you proceed if you don't have
clinical evaluation of the antibiotic used and response clinically of the patient?
And you will keep injecting the broad spectrum fortified?
If I start empirically with Fortum vancomycin, for example, here in Egypt, next one I would go for amikacin. If I'm still stuck, I think I'm going sort of vitrectomy and the tap and trying to go for a better culture.
These are the main cornerstone studies, the endophthalmitis vitrectomy study and the complete early vitrectomy. It was between 20 to 30% of their cultures were negative during the first culturing. So Dr. Mohsen said that he will proceed directly with vitrectomy, and our other dear panelists said that they will inject in such a case. Dr. Khalid?
No, I don't inject in such a case. Such a case is for immediate surgery, but the patient comes to you often in the evening hours where you cannot go any minute or any hour counts in this particular situation. So what happens if I see the patient in the office in the evening hours, whenever I cannot do a vitrectomy immediately, I inject, and next morning I do the vitrectomy.
So if you are in the best case scenario, you will go directly to vitrectomy.
With this case, well, it depends on the severity.
Depending on the vision or which severity?
In fact, vision almost always parallels what you see, the signs you see. For example, if you have this case and other cases, then we can differentiate. But this particular case is not going to benefit from injection only.
Okay, so you will inject and then vitrectomy?
In mild cases, to answer your question fully, yes, I said I inject cases, but as I said, I have very low threshold for suspecting endophthalmitis. A minimal, less than 1 millimeter hypocyon for me is for injection.
Sure, this is a frank case.
This is a frank case. This is for injection this evening, vitrectomy tomorrow.
If it presented in the morning, are you going to go
vitrectomy immediately?
Dr. Suka?
I inject.
Dr. Salam?
Yeah, I would inject, and you'd be surprised 90% of eyes get sterile with just one injection.
Same here. Yeah. My experience also.
And that's what the EDS.
This is the study of the endophthalmitis vitrectomy study that depending on the visual acuity of the patient, and they said if the patient is hand motion or more, they can benefit significantly. It was just one injection of fortified antibiotic, and there was no any outcome benefit from doing a vitrectomy for those patients?
Mustafa, this is a very old study. It's probably in the 80s.
So we will
so
discuss the issue of
no,
vitrectomy.
no.
It's coming. I'm supporting your idea at the back.
Many
Sure.
papers came afterwards
And
that
this is the
demonstrated
debate. Yes.
the shortcomings of this study.
Sure. Dr. Salam, you injected. Do you inject steroids?
I usually give them topical and sometimes usually give them topical and sometimes systemic steroid. I don't inject steroids just because I would avoid Kenalog and I may inject dexamethasone, but usually I do not.
And do you use fortified post-operative
Drops?
Yes.
No, I just give them Oflox for a few days
No fortified.
and just lots of
post-injection.
steroids. No.
Okay, Dr. Suka, please.
One, I use the fortified eye drops. Maybe not using it can work, but I mean, I have to feel that I'm giving the drug. But I never inject steroids. Never.
Inside the eye.
Never.
Okay.
Because I might need to stop it tomorrow. So I have to give something that when I decide to stop, I stop.
Dr. Suka and Dr. Salam, you injected this patient. How many of your injected patients required a retreatment or re-injection?
Minimal, 10%, I guess.
Salam.
Yeah. Again, I think if you look at the EVS was 8% in each group. If you look at recent data, it's about 25%. I think the reason is some evidence came that antibiotics, especially vancomycin, works better as a time dependent rather than dose dependent. So people are like re-injecting, but actually there's no need.
Yes, and also it depends on the virulence of the organism. This is very important. It is mentioned in all the studies. So it's around 6 to 8% will be retreated, and according to the culture, whether there is a growth or not, the percentage will differ. So if you are going to re-inject, Dr. Salam, after what time?
Yeah, I think I'm cheating from here.
It's okay.
I think you got the time right. I think 24 hours is critical, but the main really critical
36.
time is 36.
To avoid the retinal toxicity of overdose of
yeah, so I think 36-48. But the main point is to decide whether they're improving or not improving.
Sure. And this is the next question. You said it is improving or not. It could be stabilizing. Is it regarding the clinical picture or the vision improvement or just the pain is relieved? Which one of these do you depend on?
It's all of the above. And the patient usually
if the pain is relieved and the clinical signs are improving, but the vision is still hand motion.
Yeah, then she's improving.
Yeah, this is improvement.
I think you need to add really the patient perception of vision and pain, your measurement of the vision, your view of the eye, how the hypopyon is doing. If you had a B scan, then you add these together and then you come up with a conclusion. Better, worse, same.
Sure.
If it's better or same, this eye is sterile, and all what you need lots and lots of steroids.
Dr. Suka.
I think the same, but the word sterile is a lot to me. It's good. It's moving forwards. Sterile and everything under control is a bit higher.
90%.
Yeah, I get it. I get 90% single injection. Clinically, anything improved, then we're going positively. Anything. Pain on the top of the list. Patients usually come the next day. Thank you, doctor. The pain is less. And it's exactly the same. Then it's fine. He goes on to be fine.
This is a perfect introduction for the next scenario. This patient was a hand motion on the 3rd of March, last March, and he was injected based on the endophthalmitis vitrectomy study, and he had a post-cataract 5th day endophthalmitis. Okay. So, and he improved after 15 days, and he was on oral steroids. 1 month later, he presented with this choroidal detachment, and the pain started to appear again, but not due to the endophthalmitis. It's because due to the hypotony. And the vision now is a PL vision. So it's worsening now, Dr. Suka. What is your next step? Are you going to retreat? Are you going to add steroids?
The drop now is due to hypotony in a quiet eye, I guess. AC is it's a bad luck patient. I don't think we can recover from this. Steroids all over the place.
This is a different ball game altogether. This is like, it's now, usually when the eye improves, it just continues to improve, full stop. Then now
Sometimes
he developed maybe retinal detachment. Yeah, it's a different ball game now.
That was my question.
Yeah.
That the vision has to improve even later and not getting worse. Because if we depend on clinical sign and pain only for the first few weeks, and you stop injecting those patients or treating those patients, you may be confronted with this sequelae of endophthalmitis with choroidal detachment.
This is a different ballgame.
Sure. This
Mustafa,
patient received.
excuse me, I just want to comment about this. Your goal by treating endophthalmitis is to get a sterile eye or seeing eye? Both.
Sterile eye, which leads to the
Okay,
seeing eye.
so by injection, in my opinion, and I want
This
Dr.
is
Khalid to comment,
It will
do you want
come.
a sterile eye after 15 days or you want a seeing eye? This is maybe related to the toxicity of the organism. You have a multiple toxin. You have a very high load of toxins in the vitreous and
But
the
the
anterior
vitreous
chamber.
now is clear. It's
Do
a
you think
choroidal detachment.
this
Yes,
vitreous is
on the second one
Okay.
compared to the first
okay?
one.
I'm talking not about the micro. I am talking about the toxins. I'm talking about the extensive corneal scarring and the decompensation, which is going to happen.
So it is prescribed that based on visual acuity, you can inject. This is not.
This is according to the AVS.
Yes.
Yes.
And
Okay.
the recent one we will
Which
discuss
is doubtful nowadays.
Okay, could be.
Yeah.
So this patient received steroids, improved after 2 months, and the vision now is counting finger because of these vitreous membranes. So, Dr. Suka, how many of your injected patients required vitrectomy after some time?
10 to 20% for the opacities after a very quiet, nice eye. It's lots of membranes. I clear the membranes and it comes
So
out
you
like a
prefer-
diabetic vitreous hemorrhage case.
You prefer to have a vitrectomy in a calm
Yeah,
eye? Than
yeah.
Dr.
After
Salam?
1 to 2 months.
I would second this. This is exactly
Yes,
our,
it's
our
10% in the endophthalmitis vitrectomy study and 50% in the TAP group, because in this other study, complete early vitrectomy study, they are aiming for a clear media. So 50% of those who received the injection received a vitrectomy later on. So this is the other side of our talk, and this is how Dr. Mohsen and Dr. Khalid will be happy. Is it still valid guideline for the endophthalmitis vitrectomy study? Actually, it is better to have everything clean and green as early as possible, because it is now proven that there is what is called a macular hypopyon and an endophthalmitis maculopathy. Whether you get this patient treated early or late, those patients are losing some of the retinal tissue if you left this part of the hypopyon lying over the macula. And this is the complete early vitrectomy study that was comparing just the injection versus complete as possible early vitrectomy with systemic antibiotics that was negated in the early study in the endophthalmitis vitrectomy study. And they even asked for adding more vitrectomies if you have a persistent or a recurrent media opacity during the follow-up period of those patients. And they recruited around 62 patients. 77% were treated with complete early vitrectomy and 23% with injection. 61% of those patients in the two groups received more than one treatment, whether vitrectomy or injections. And in this study, the rate of achieving more than 612 was higher than the endophthalmitis vitrectomy study, reaching to almost 80%. So if you treat those patients with an early vitrectomy, you can achieve more than 612 in your patient. And this patient is just a typical example was about what Dr. Khalid and Dr. Mohsen was telling us. This patient received, he presented after cataract surgery 5 days after surgery, and he received 3 intravitreal antibiotic injections 48 hours apart between each injection. And as we can see, this is a very dense vitritis even after the third injection by 48 hours. And there was still hypopyon. There is a corneal bad condition with corneal edema. And as we can see, there is a lot of inflammation taking place. There are snowballs. Probably we will see that there is a retinitis. And everything is a little bit more complicated even after injecting those patients. By the way, this is also depend on the virulence of the organism, which was brought back from the lab to be a Pseudomonas, which is one of the most aggressive microbial. And it was advocated in this study that to do as complete as possible, to do, even if you can, to do a PVD, try to do a PVD without inducing any iatrogenic breaks. And this is a good example of, as we can see, there are some parts of this fluffy pre-retinal hypopyon that can be removed or aspirated, and leaving this retina in a more healthy and fresh way compared to what we can see now in this macular area of this patient, that the hypopyon is attached and adherent to the macula of this patient, and we cannot remove it. compared to this other lucky patient that presented again on the 6th day of combined shunt and cataract surgery. And as we can see, just aspirating the pre-retinal hypopyon or pre-retinal pustular material, it can get away, and we can over the macula, we can propagate, and we can even induce a little bit part of the PVD, as we can see, and you can keep the fovea intact, and you can remove the hypopyon to avoid an endophthalmitis maculopathy or a premacular hypopyon. So, Dr. Mohsen, what is your opinion now?
It's okay. This is my opinion. You said everything I want to say.
Okay, so you prefer to go for just this directly without doing any injection for all endophthalmitis cases?
Yes, as early as possible.
Depending on the media clarity, right?
No.
For every, even if you
If
can,
I'm sure this is a case of endophthalmitis,
so you go for vitrectomy.
yes, and I'm sure if this case of endophthalmitis, the media will not be clear.
Dr. Tsuka, please.
Yeah, I want to mention that I don't inject more than twice. Third time, it's a vitrectomy for me. So this is previously injected, not good, you go to vitrectomy. Yeah, sure. I never said I'm not doing a vitrectomy forever.
Sure.
That's one thing. The idea that we're presenting is you see the patient, you go for a vitrectomy. I'm against it 100%.
The evidence nowadays, and it shows.
I don't see the evidence. The paper said, yeah. The evidence is not sufficient. 14 cases injected. We don't know even how many of them are seeing better. 10 more cases would change it to a different story.
There's complete wrong interpretation of the complete early vitrectomy study, and I think it's for some reason I'm not sure why people are interpreting it wrongly. First, it's a retrospective study of about 40 eyes. I don't think actually. I think they analyzed even like 38 at the end when you look at the tree more carefully. I think they even went down to analyze 30. But anyway, in that study, they actually injected patients and they did vitrectomy early. So they did inject patients, but they did vitrectomy early regardless of the vision and within 24 hours. That's why they called it the complete early vitrectomy. So actually they're doing what we've done. Other than that, if you look at all the big data actually now, like the IRIS registry study just came like a few months ago, and that showed there's no difference. We did a study from in 2021, actually, was a big data study as well from European Center, and it showed no difference. So yes, I think theoretically you think remove the pus, but even data from Manchester showed that you lose more eyes by surgery. These are very hot eyes. You get one break, you lost the eye. So I think what I'm just advising is look at the evidence.
So, okay, this is a very good point. Regarding the tears and retinal detachment, it was found by comparing the two studies. It is more in the endophthalmitis vitrectomy study, because leaving these hypopyon over the retina will induce a more atrophic and moth-eaten appearance of these tears and will induce more retinal detachment. And it was interesting for me that if you can see the no PL patients treated in the TAP and inject in the endophthalmitis vitrectomy study, there were 4 patients lost vision, and they were injected in the endophthalmitis vitrectomy study with a better vision than hand motion. So those patients turned in no PL. This is the study, and this is reported. And compared to in the vitrectomy study, just one patient that underwent vitrectomy had the bad scenario with retinal detachment, and it was not iatrogenic. Again, it was due to retinopathy of.
I think you're looking at 48 eyes compared to a prospective study with 2 arms and more patients. Yeah. So I think the interpretation is not the same. But and it's also like what's the word? Like the number of patients you need to treat to get the outcome.
Sure.
What's the word? There's like a word.
The N of the study, the minimal number, power of study. But I want to mention something. We always think that looking something yellow on the surface of the retina means it's toxic to the retina. It doesn't work this way. Microbiology and chemistry don't work this way. They look yellow, but if you inject and our organism is not live anymore, it's not producing toxins. There is no toxin in the yellow thing you're looking at. Removing a yellow thing doesn't reduce toxicity of the tissue.
You don't When every every brain was encephalitis, right? Like you treat them medically, and these are like super MIC, super minimal inhibitory concentration.
As
But
we
anyway,
can see,
it's
there
a discussion that it's a
Sure.
debate never.
as we can see, that endophthalmitis still is a poor consensus area that we have. These eminent panelists are in a conflict. So let's have this interesting game of agreement based on most of the consensus and evidence present nowadays. So Dr. Suka, if you have a case of acute postoperative endophthalmitis, I know your opinion, but let's proceed. Will you go for tap, inject, and delete vitrectomy?
Yes.
Dr. Mohsen?
Vitrectomy, early vitrectomy.
So we have this debate, but most of the, as Dr. Salam said, it goes to doing an injection and postpone a little bit the vitrectomy, despite that I'm seeing keeping everything green and clean now is better. Dr. Khalid, please. Chronic post-operative endophthalmitis, would you go directly to an early vitrectomy?
That has not been injected before, or that has been injected and remained chronic?
It's just a chronic case presented 6 months after cataract surgery. It's a chronic one. A delayed post-operative. It is not an acute.
And vision?
And motion.
Well, probably it. Well, I will try injection because there is no hurry. There is already a chronic case, so I will try injection. But most likely, I don't expect a very good outcome from injection.
So we will proceed to vitrectomy.
If injection does not work.
The most of the literature that post-operative chronic endophthalmitis requires surgery, and it is advised to be titrated to remove the cake or the retrolental plaque, and to go slightly, not to remove the lens and the capsule all in one bunch at the first surgery. And if we have time, we are going to see.
But I think it depends how it looks. I mean, if you get some cells early endophthalmitis, everybody here will inject. If it looks with lots of cake and stuff, that probably
no. This is just presenting most of the evidence to get time. So, Dr. Salam, if you have a lab-associated endophthalmitis, and you wrote a paper in this, so to which side are you going to? Is it injection or?
Actually, we did not write a paper on the. Actually,
it's a book.
Yeah, chapter. No. Actually, you're right. The European study included these cases, so we would do the same. The problem is the organism is more virulent. I think you can consider vitrectomy early, but again, time is counted. I would inject, and maybe like instead of the second time injecting without vitrectomy, then I'll be like ready for the second time. If it doesn't work, I'll go vitrectomy.
Same opinion, exactly. Inject, rapidly go to vitrectomy, not delayed.
So this is an early vitrectomy, what I mean. Dr. Salam, again, please, regarding the endogenous fungal, would you go for injection and systemic, or systemic with vitrectomy?
No, so this is a good one, and we studied this. So if the lesion, so if it's ordinary chorioretinitis, which is not very raised, systemic treatment is more than enough. But if it's vitreous involved in endophthalmitis, then you actually systemic medications are not enough because their penetration of the blood-retinal barrier is not enough. So systemic, and we'll also give intravitreal. Vitrectomy does not improve the vision, but it may decrease the risk of retinal detachment.
This is Salam et al. In his paper.
That's what we found.
I do the opposite. Very rarely endogenous fungal, I go for vitrectomy. Inject systemic, wait a lot. My experience in vitrectomized eye is so miserable. So miserable.
Maybe it's related to the organism. In our country, it's Aspergillus mostly. Maybe it's Candida in the USA.
But in the COVID area, we found a lot of Candida.
Yes.
Dr. Khalid, if you have a case of endophthalmitis with traction retinal detachment, which one?
Well,
there is a detachment found.
It will, of course, it will end up with vitrectomy, but whether it should be early.
Yes.
It should be early vitrectomy or not. That's the question. But
the last one, if diabetic patient, if he is diabetic, would that change your?
No.
You start with injection and then vitrectomy if it needed.
Definitely.
So, unfortunately, due to shortage of time, we have all these topics to discuss, and I would like to thank the organizing committee. And we are going just one slide, please. And I would like to invite you all for the next summit here in Radisson Blu in September to discuss the endophthalmitis more. And I would like to thank again Dr. Ashraf and Dr. Mohsen for the kind invitation, and thank you for your kind attention.